Good afternoon, everybody, and welcome to our symposium. My name is Michael Niederman, and I'm from New York, and I'll be moderating our symposium today, which is devoted to the treatment of multi-drug resistant pathogens causing ventilator-associated pneumonia. I think we're all very familiar with the challenges in dealing with these difficult-to-treat pathogens in patients with pneumonia, particularly in the ICU. And for a long time, we've had very few treatment options available for us in dealing with the most difficult pathogens. Today we're going to explore three different avenues for improving the therapy of MDR pathogens. I'm going to first talk about some new antibiotic developments specific to ventilator-associated pneumonia. Carlos Luna from Buenos Aires is going to discuss the potential of using aerosolized antibiotics to treat ventilator-associated pneumonia. And Jean Chast from Paris is going to discuss non-antibiotic therapies for pneumonia. And I guess in a general way, this symposium is good news. It's good news because we are talking about something that we haven't had in the past, which is options that may be emerging for the treatment of difficult pathogens. And so in that regard, it's good news. It's also, I think, good news because this symposium is sponsored by the Academy of Infection Management. And this has been an organization that's existed for many years. It's been on a hiatus recently, but it's been very much committed to education of physicians and healthcare providers in the treatment of difficult infections, particularly focused in the intensive care unit. So we're very excited to be able to do this symposium and to do it on behalf of AIM, as I think this organization is going to be able to provide education on an important topic in the future. So I'm going to be talking about new antibiotic developments for ventilator-associated pneumonia. And the question is, can these new antibiotic developments help us in the intensive care unit? I've listed here my potential conflicts of interest. And again, I think it's interesting to get the historical perspective on where we stand with antibiotics. We have very bad bugs, and it's not what it was when antibiotics were first developed in Fleming's era. This was a list of his sensitive and resistant pathogens, and if you look at the organisms that he was concerned about in the 1940s, it was nothing like the difficult pathogens we deal with today. We have increasingly drug-resistant pathogens. The escape pathogens, I think, may be known to all of you. Not all of these organisms cause pneumonia, but escape is a algorithm that stands for Enterococcus faecium, which is VRE, Staph aureus, Klebsiella, E. coli, and ESBL producing organisms, as well as those who produce carbapenemases, Acinetobacter, Pseudomonas aeruginosa with multi-drug resistance, and the Enterobacteriaceae. And of course, all of the organisms shown in yellow here are the gram-negative pathogens, which we're particularly concerned about causing pneumonia. Staph aureus is an important cause of pneumonia, but of course a gram-positive organism. And of course, every year things get worse. This is one of the earlier reports about the metallo-beta-lactamases and the New Delhi beta-lactamases, which again are highly resistant to almost all classes of antibiotics. So why is resistance such a problem? And the answer is, of course, we're using too many antibiotics. I don't know how many of you are familiar with Pogo, cartoon character, but I think he said it very well. He said, "We have met the enemy and he is us." We are the problem. We are responsible for antibiotic resistance because we overuse antibiotics. And there's certainly been a renewed interest, of course, in the United States with antimicrobial stewardship, but I think around the world there's been great interest in avoiding overuse of antibiotics so we can preserve what we have. And as you may know, the Infectious Disease Society of America developed their 10 by 20 campaign under the guise of bad bugs need drugs. They wanted to develop 10 new antibiotics by 2020. And I would say realistically, that is likely to have happened. I think that we have a number of drugs, as I'll show you, in development, and it's promising that we might be able to use some of these agents in the intensive care unit. There's a lot of reasons, though, that we have not had drugs developed for a long time, and I think that some of it is regulatory and some of it is financial. And I think it's important to look at the financial implications of antibiotics, because because I think it's becoming less and less interesting for pharmaceutical companies to develop new antibiotics. For example, they could develop a new antibiotic at a tremendous development cost, and it would not cost them any different to develop a new drug for musculoskeletal disease, diabetes, hypertension. Those drugs, if a patient starts taking them, they may take them for years. Antibiotics are very short term, and although there are many more people who might need antibiotics, the profit margin on antibiotics is probably less than some of the other drugs that they could develop for the same cost. As I mentioned, there's a great interest in stewardship, and all of the guidelines now are focusing on shorter courses of antibiotics, and that's really in contrast to chronic use of drugs that we see in chronic disease. And so the most that probably a drug could be reimbursed is $3,000 per case, and again, if they develop a new chemotherapy drug, they might get $60,000 for a single treatment with some of the newer chemotherapy agents. So there's a number of financial reasons that pharmaceutical companies have not been particularly interested in developing new antibiotics. And again, if you're interested in this, I won't belabor this. There's a very nice review in the Blue Journal several years ago that talks about why antibiotic development is so slow and what some of the solutions might be. But again, I think we're only seeing some of that happening, and you're going to hear about some of these solutions today. On the other hand, I think we're aware of the problem with new drugs, and even as early as in the 40s when Alexander Fleming, in 1945, who had been the Nobel Prize winner, as you know, for developing penicillin, in his Nobel Prize lecture said, "There is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant." So I think we were aware a long time ago of the potential of these new drugs to not necessarily work indefinitely, and resistance has always been in the background. There's an unmet need for new antibiotics. This was a review of the Emergent Infection Network members. Over 500 people responded, and they rated their unmet needs for treatment of infection on a scale from 1 to 5, and MDR gram negatives were the number one unmet need. New antibiotic development they thought was the best strategy to develop or to meet this unmet need. So there's no question that everybody perceives the need to develop these new antibiotics. There are a number of drugs now available for gram-positives that are being developed. The oxazolidinone class is active against linezolid-resistant MRSA. The oxazolidinone class, of course, includes linezolid, but in development now is tadazolid, which has lower MICs than linezolid against MRSA. It has once daily dosing, no serotonergic agent interactions. Skin and soft tissue infection trials are done, and there are ongoing studies now in healthcare-associated pneumonia and ventilator-associated pneumonia. Ridazolid concentrates in macrophages and neutrophils, and is another agent in the class that's being developed. The glycopeptide cephalosporin heterodimer that really only has a number now is active against gram-positive infections, including VAP with bacteremia. There's a phase 1 trial that's now being conducted with this agent. In the tetracyclines, we have omadacycline, which is both IV and oral, primarily used for community-acquired pneumonia, but does have activity against Staph aureus and some gram-negatives. And so many people have sort of anticipated that this is similar to an oral version of tigecycline with both an oral and an IV option, and we may see this be developed for the treatment of ventilator-associated pneumonia as well. Tadazolid versus linezolid have been compared, and again, tadazolid is a little bit more active, particularly against MRSA than linezolid. Again, I apologize for these MIC slides. I don't really like reading them, but I flashed them up here to show you the references if you want to look a little bit more closely at some of the activity of individual drugs. There are a number of drugs now that are being developed for gram-negative VAP. Those include ceftolozane tazobactam, ceftazidime avibactam. I think these two beta-lactam, beta-lactamase inhibitors are the ones that we probably ought to be spending the most time thinking about. Both of them have approval. One of them, ceftaz-avibactam, is approved in Europe now for pneumonia. Neither of them are approved for pneumonia in the United States. There's an aztreonam-avibactam, which is active against metallo-beta-lactamases. There's a siderofluorocephalosporin being developed. There's carbovance. There's a meropenem with like agent, which is with an inhibitor called vaborbactam, which has enhanced activity against KPC-producing organisms. Imipenem relebactam is being developed. Plasmomycin, which is like an aminoglycoside. There's a new macrolide inhibitor, and there's a cyclopeptide. And again, all of these may sound unfamiliar to you, which to me is very good. It's very good because it means that we really do have antibiotics being developed in different classes than we're familiar with, and all of which have the potential to help us in very difficult situations. I think the biggest development, however, in new antibiotics has been the new beta-lactamase inhibitor. And there are now 3 beta-lactamase inhibitors. There's avibactam, there's relebactam, and then there's vaborbactam, which is the one that's got the numbers here. And again, if you look at them, they're all good against Class A narrow-spectrum beta-lactamases. They're all good against Class A ESBLs. But against the carbapenemases, not tazobactam, but all 3 of the new ones, some Class C beta-lactamases, all are active again. And avibactam is the only one that's active against Class D beta-lactamase producing enzymes. And so these are all new developments that potentially can help us. And I've developed this list here that talks about new drugs in the pipeline for resistant gram-negatives. Ceftolozane tazobactam is approved now, but not for the treatment of nosocomial pneumonia. Ceftolozane is a new beta-lactam that's got enhanced pseudomonal activity over the previous beta-lactams. It's with a very familiar beta-lactamase inhibitor, and there are ongoing trials now in ventilator-associated pneumonia. Ceftaz-avibactam has been a very familiar beta-lactam, but a new beta-lactamase inhibitor, which, as I pointed out on the previous slide, is probably the one that's most active against all the different classes of beta-lactamases. And again, it's got good pseudomonal activity as well. Ceftaroline-avibactam is primarily an MRSA drug, and again, what role it'll play in VAP is to be determined. The new cephalosporin beta-lactamase inhibitors are only available intravenously. Ceftolozane tazobactam and ceftaz-avibactam, again, are active against Pseudomonas. Ceftaz-avibactam is active against a very broad range of KPC-producing organisms, and tazobactam may be different from the avibactam because tazobactam has irreversible binding, whereas avibactam is reversible and can be recycled, so that potentially avibactam could recycle after the organism is killed. If we look at the activity against these new drugs, again, ceftolozane tazobactam and ceftaz-avibactam have very similar spectrums of action. Again, probably ceftolozane is a little bit more active as an anti-pseudomonal agent, but again, ceftaz-avibactam is also a very good pseudomonal agent as well. I won't go through again the MIC data, but the references here if you want to look closely at the in vitro activity of ceftolozane tazobactam and ceftaz-avibactam. Those numbers are published. And if we compare these two drugs to one another, again, ceftaz-avibactam is active against KPCs and ESBL. The dosing is 2,000 milligrams of ceftaz with 500 milligrams of avibactam, so a 4-to-1 ratio. It has predictable pharmacokinetics, rapid drug distribution, and renal excretion. Ceftolozane avibactam is extremely active, again, against ceftolozane tazobactam is extremely active against pseudomonal resistance mechanisms. It's dosed in a 2-to-1 ratio, 2,000 milligrams of ceftaz, 1 of of ceftolozane, 1,000 milligrams of tazobactam. Now, in the United States, this dose, which is referred to as a 3-gram dose, is not approved for the treatment of pneumonia. The dose that's approved for skin and soft tissue infections is the 1,500. And the trials that are ongoing now in the treatment of ventilator-associated pneumonia use this higher dose of 2,000 milligrams of ceftolozane, 1,000 of tazobactam. So I think if you're going to use it off-label to treat VAP, you need to use that higher dose that, again, is not approved in the United States. It's active against ESBLs, again, also predictable pharmacokinetics with rapid lung distribution and renal excretion, but it doesn't have KPC activity, whereas avibactam, again, is active against KPCs. Again, the dosing we mentioned, but again, if you're going to use ceftolozane tazobactam, it's important to give the 2-gram dose. When you're using ceftaz-avibactam, 2 grams plus 1, so the 3-gram total dose. When you're using ceftaz-avibactam, you can administer it as a 2-hour infusion, which I think is really an advantage for targeting potentially more resistant pathogens. Again, this is a distribution of target attainment in epithelial lining fluid following the highest dose of ceftolozane tazobactam. And again, if you want to target the most resistant pathogens, you need to use that 3-gram dose. The 1.5-gram dose, which is approved but not for pneumonia either, doesn't target nearly as resistant organisms as the higher dose. So again, if you're going to use it before all the trials are done to treat VAP, I think most people would recommend you use the 3-gram dose, which is again 2 of ceftolozane and 1 of tazobactam. A couple of other drugs to think about. Relebactam is imipenem relebactam, which is another beta-lactamase inhibitor, active against KPCs. Plasmomycin is called a neoglycoside. It's very much like the aminoglycosides. And brillicidin is a peptide defensin protein, a totally different type of mechanism of action than some of the cell wall antibiotics we've been talking about. So if you go to clinicaltrials.gov, you can get updated on where we stand with some of these drugs in VAP trials. Ceftolozane tazobactam in the 3-gram dose is being compared to meropenem for nosocomial pneumonia. This is a drug that's been developed by Merck. The endpoint here is all-cause mortality in a little over 700 patients, and the trial is still ongoing. Imipenem relebactam, which is another Merck product, is being compared to pip-tazobactam for hospital-acquired pneumonia, including VAP, and again, they're looking at 28-day survival. And tadalafil, again, another Merck drug, is being looked at the 200 milligram dose a day daily versus linezolid 600 milligrams twice a day, and again, all-cause mortality at 28 days is the endpoint. Now, it's very interesting to think about the way that these trials have been designed, because Merck has been very much attentive to the US FDA recommendation that all of these drugs have to show non-inferiority for mortality. So in all of their trials, their endpoint is mortality and demonstrating non-inferiority. That's not necessarily the case for some of the other drugs. Plasmomycin is being tested with adjunctive antibiotics, also looking at all-cause mortality. But if we look at the ceftaz-avibactam trial, it's being compared to meropenem. It's including VAP and non-ventilated pneumonia. And here the primary endpoint is clinical cure. And this trial has been completed, and it's the basis of the drug approval in Europe. But I think there's some serious discussion as to whether or not this is going to present a problem in the United States, because what's potentially problematic in the United States for approval is they didn't use as their endpoint all-cause mortality, and they also mixed VAP and non-VAP. So I think when we're looking for which drugs will be approved for VAP, I don't think we know if this trial design will or won't present a problem. If you actually go to the website and read about what they've done, they've enrolled 356 patients who got ceftaz-avibactam, 370 who got meropenem, Again, the clinical cure rates were, again, quite similar, and there was a slightly better p-value for clinical cure with the ceftaz-avibactam. They got similar data for test of cure at the end of therapy, but again, no comment here about all-cause mortality. So I think what the only editorial comment I'll try to leave you with is if we're really going to use these drugs to improve ventilator-associated pneumonia management, I don't know if these trial designs are really going to do it for us. Because all of these trial designs, no matter whether the endpoint is clinical cure or mortality, are designed to show non-inferiority, and they generally require that the pathogens be sensitive to both the new drug and the old drug. So in other words, by design, none of these trials will ever show whether or not these new drugs could help us with our most difficult to treat pathogens that can't already be treated by existing drugs. Because to get into any of these clinical trials, the organisms have to be sensitive to an existing drug. And I think what might be better is that we design for superiority against the best available therapy using the new agent and using highly resistant pathogens. Take pathogens that we probably couldn't treat today and treat them the best way you could without these new agents, and use these new agents with maybe the best available therapy as well, and see if there's truly superiority. And again, I've turned to a very famous quote from the past: every system is perfectly designed to get the results it gets. We have trials that are perfectly designed to not answer the question, will these drugs work in situations that our current drugs don't work? They're not designed to answer that question, and that's the only comment editorially that I would say we really need to have that question answered. So to conclude, there are some new agents in development and being tested in clinical trials. There may be new therapies for VAP, both IV and aerosol, which Carlos is going to talk about, but the trials are designed for equivalence, and to me that's a potential problem. Most of these drugs are modifications of older agents or with the addition of a new beta-lactamase inhibitor, but there are some new classes. There are pleuromutilins, there's the sideroflor, can't pronounce it right, the monosulfactam, the cyclopeptides, and the peptide defensin protein mimics. And again, I think the other question that many people have talked about, which to me is not really the answer we need, is if we're going to design these trials to show equivalence and not superiority, then at the maybe what they can help, these new agents can help us with, is stewardship. Maybe we could use them in place of carbapenem and make them carbapenem sparing agents, but I'm not sure that it really has been worth all this effort to develop new agents only to be told we can't prove that they're any better than the old agents, so let's use them instead of the old agents to spare some of these agents so that they too will remain active for a long time. So my only real concern is we have a number of exciting new drugs, but I'd like to see the trials be better designed to really test the potential of these drugs to help us in situations where we just don't have answers today. Thank you very much.